So today we're very happy to have Dr. Novak here. He's one of our own. He is the medical director of nutrition here at Mount Sinai Hospital. And he's going to make some very interesting talk we haven't had done before, actually, on popular diets that our patients may be coming in with, and to kind of enlighten us on those diets so we're better equipped to answer their questions. So thank you, Josh.
Thank you. Morning. So I was charged with this task. I didn't really have a grasp of how much information is out there, both in Google and the web as well as in the medical literature. So basically the goals of this talk are for us to understand the potential benefits and risks associated with popular diets commonly used by our patients, and to recognize also that there are nutritional issues that can arise when our patients come in. They're like, oh, I'm not feeling well, I went on this diet, I went on that diet, or I'm trying to lose weight. So what are the popular diets out there right now? Now, according to this News and World Report, the most popular diets are the Mediterranean and DASH diet, followed by the flexitarian, Weight Watchers, and other commercially available diets, and the MIND diet. If you go down in terms of the recommendations, some of the most popular ones you hear about, the keto diet is ranked 39th out of 39. You know, whole 30 is 37th. The vegan diet's 19. I'm also going to touch on a couple diets which weren't on there, the mindful eating and the intermittent fasting diet as well. And these were sort of rankings were done but they brought physicians as well as dietitians together and sort of ranked not only for the popularity, but also the quality of the diet and the food. So obesity, there's 1.9 billion adults overweight in the world and 600 million that are obese. And obesity, again, at BMI greater than 30 and overweight at BMI greater than 25. The prevalence has tripled since 1975. Disease associated with obesity, we know cardiovascular disease, diabetes, osteoarthritis, some cancers, as well as really morbid obesity is related to an excess of energy intake and then a lack of energy expenditure, what goes in, what goes out, for the most part. Not always. The problem with obesity is many of our patients are consuming diets that are unhealthy and low nutritional value. These are carbohydrates, a lot of refined sugars, white rice, fats and oils. The intakes in fruits and vegetables may be limited. At any given time in the United States, approximately 45% of women and 30% of men are currently trying to lose weight. So it's a staggering number of patients. Approximately $33 billion is spent annually on diets between books and diet plans. What do? You have patients, they try liquid diets, they try, keto diet. If you just Google some of these diets after the lecture, you'll see books, web pages put up by physicians, dietitians, other health gurus, feigning health gurus. So obesity, what are these patients walking in? They can start malnourished even prior to dieting. If you look at sort of the gastric bypass literature, they've extensively looked at this, and they looked at one study looking at patients that average intake around 2,800 kilocalories, the BMI of 43. 7 patients reading over 4,000 calories a day. They did a food questionnaire, and just serving the food questionnaire, only 76% had adequate iron, 20% had adequate vitamin D, and 81% adequate calcium. They measured deficiencies in these patients prior to going to surgery. 12% were iron deficient, 2.9% had zinc deficiency, 2.3% had phosphorus deficiency, 13% were anemic. Zinc deficiency, again, we're looking at sort of a low quality diet. B12 deficiency, 71% had low concentrations of vitamin D, 66% had high levels of parathyroid hormone, but no folic acid or copper deficiencies. Folic acid deficiency, the lack of that's probably likely the fact that folic acid is supplemented in a lot of our foods. Again, looking at other patients, looking at over 1,700 Caucasian patients, 63% had a deficit in folic acid, 97% had a deficit in vitamin D. These patients, again, there was vitamin B12 deficiency, vitamin A deficiency. So really, if you look at the guidelines, yeah.
What percent of the general population is low in vitamin D? General.
It's hard to say.
I'm not sure that that's an obesity.
It may not be an obesity issue. I just think that they did a large, you're right, they did a large sample looking at these patients, and the point that I'll get to in a second, I'm jumping ahead, is that if you have an obese patient, you just screen them. And a lot of times they are screening these patients now going in. So I guess the point of the initial part of this lecture is to sort of discuss that patients going into diets can often go in malnourished. And then they're going to go on a diet, which we'll talk about, and issues can arise. So to sort of be proactive with them.
It's unusual when we do a lab screen, finding
True. And especially in New York City, where we have buildings and there's a lot of shade, so we're not getting vitamin D from sunlight a lot of the time. So, you're right. If I was a resident when I was an intern and I got a vitamin D, I wasn't shocked it was low. I was also the same color as my white coat because I would get it on the sun. So, what is the Mediterranean diet? So, again, it's a diet very heavy. It's sort of it's a food pyramid, sort of a twist on the food pyramid that we see from USDA, looking at high in fruits and vegetables, be physically active, enjoying meals with others. You know, you get a lot of fish and seafood, poultry, eggs, cheese, and yogurt, sort of a little bit last, and then meats and sweets are very little. Of course, a lot of people like the fact there is wine in the Mediterranean diet, as well as drinking plenty of water. So nutritional, again, the Mediterranean diet, lots of fruits and vegetables, nuts, legumes, unprocessed cereals, low consumptions of meats, and low consumptions of dairy with the exception of HGs. Alcohol consumption is common in the Mediterranean diet, coming from the Greek word symposium, but generally in moderation in the form of wine. Total intake of lipids can be high, up to 30–40% of calories, but these are, again, monounsaturated and polyunsaturated. And monounsaturated contents literally used in olive oil, so you'll see sometimes up to a half a cup of olive oil a day in some of these patients. Fish consumption at a moderate level as well. There's really not many pitfalls to the Mediterranean diet. Looking at a cancer registry in Italy, they looked at just a general population screening in 2015, looking at the cases of colon cancer, and they found a disproportionate lower incidence of colorectal cancer in southern Italy, and they said this might be due to lifestyle differences, probably different eating habits. In southern Italy, they really do follow the Mediterranean diet a lot more closely than they do in northern Italy. So then they did a European perspective investigation of cancer nutrition in the EPIC trial, not the medical record system some of us hate. The Greek segment of EPIC, there are over 23,000 men and women not previously diagnosed with cancer, coronary disease, or diabetes, and they looked at survival status until June of 2018. There was a higher adherence to the Mediterranean diet associated with a reduction in total mortality. They looked at the contribution of 9 components, and adherence to the Mediterranean diet is approximately additive, basically. So the more you follow the Mediterranean diet, the better you did. But they really found that predictors of lower mortality were moderate consumption of alcohol, low consumption of meat and meat products, and higher consumption of vegetables, which we've seen in the United States, vegetables and then red meats and preserved meats. So dietary fats in a modernized Mediterranean diet compared to a Western type, the fat is slightly higher, not different, comparing to our traditional Western diet. The fats are slightly higher. Plant animal saturated fats are lower. Monounsaturated much higher. We talked about a lower rate of animal omega-6. Plant omega-6 is also lower. N3 or omega-3s are much higher. Omega-3s, obviously fish and seafood are higher. Much lower in the industrial trans fatty acids. Again, they're eating less processed food. And natural trans fatty acids are slightly higher to not different. So what about if you don't restrict the fat of these patients? You do whatever you want in terms of the fat content. They did a systemic review and meta-analysis looking at, again, the 7 main components of the Mediterranean diet, but they wanted them at least to include 2 of these components in the systemic review and meta-analysis. They compared the lowest quintile to the highest quintile of adherence to the Mediterranean diet, was associated with a lower cancer mortality, increased incidence of total cancer as well as colorectal cancer is also slightly lower. There was inconsistent, minimal, or no evidence pertaining to outcomes, adherence, and hypertension, cognitive function, kidney disease, rheumatoid arthritis, or quality of life. So they looked at just cardiovascular disease in the Mediterranean diet. There's been a lot of papers on this. There was one other meta-analysis, a Cochrane systemic review, where they looked at lipids, and there was a slight reduction in cholesterol and LDL. And basically, the subgroup analysis revealed statistically greater reductions in total cholesterol, described in intervention as a Mediterranean diet, and then as well as reductions in blood pressure seen in 3 of the 5 trials reporting this outcome. There's the Leon Diet Heart Study. This was sort of the big study, one of the studies that put this on the map. It was done from the New England Journal of Medicine in 2013, and they looked at 605 patients who had a previous MIs. These are high-risk patients. They randomly allocated the Mediterranean diet to the AHA Step 1 diet. The Mediterranean group was advised to increase consumption of vegetables and fruits and then decrease their consumption of red meat. They asked to replace butter and cream with special linoleic acid-rich margarine. There was a 73% relative reduction in coronary events over the next 27 months. What about the olive oil? So what is the Mediterranean diet that's driving this? Is they looked at, they found that compared to the lowest quintile, the highest category of olive oil consumption associated with lower odds of having any type of cancer. Olive oil consumption associated with lower development of breast cancer. Cancer of the digestive system was also down. But it's unclear whether olive oil's monounsaturated fatty acid content or its antioxidant components are responsible for the beneficial effects of olive oil. And this property is referred to by its content of monounsaturated fats, mainly oleic acid. Colon cancer, obviously very important to all of us here. Reduction in colorectal cancers, that's greater than 20%, has been linked to fruits and vegetables. We know that. Health benefits of tomatoes, possibly due to the carotenoids, primarily beta-carotene and lycopene. Again, looking at the EPIC study, they did a control study looking at, the dietary intake of carotenoids and vitamin A, C, and E with the risk of colon cancer. And they found that increased plasma retinol inversely associated with proximal colon cancer. Vitamin B's and C were inversely associated with distal colon cancer. They suggested fruit and vegetable consumption confers a protective effect based on its antioxidant properties. But however, clear evidence is still lacking. So when a patient comes to you and they say, well, for the Mediterranean diet, I'm going to prevent colon cancer. No, but you could say, look, we know vegetables, we know decreasing your red meat, there is data supporting this, eating a healthy diet. So that's sort of, again, that's why I sort of bold this in the and made a point that you just not prevent cancer, but there are health benefits to this diet. So we need to explain to our patients the complex interaction between active compounds in foods, bioavailability of antioxidants in humans after ingestion of food. It's very difficult to identify the quantity of specific nutrients that could prevent carcinogenesis. And cancer results from a combined effects of many factors: smoking, lack of physical activity, genetics. There's a lot of variability in the development of cancer. So that's why I'm sort of really making a point on this, that there is benefits to this diet, but it's not a cure-all. We have to be very careful with our patients because they Google everything all day long. And I see this all the time when I see patients in my clinic. So another diet popular does the DASH. The dietary approach is to stop hypertension. The DASH diet, it stresses consumption of foods rich in protein, fiber, potassium, magnesium, and calcium, vegetables, beans, nuts, whole grains, and low-fat dairy. Limits foods high in saturated fat. It's not a reduced sodium diet, actually, but its effects are enhanced by also loading sodium intake. And compared to a typical controlled diet consumption, DASH has shown that systolic blood pressure and diastolic blood pressure drop of 5 and 3 respectively after 2 weeks. It's particularly helpful in those with hypertension already. Among African American individuals, again, you had a 6.8 and 3.7 drop of mercury respectively. DASH has been consistently part of the national blood pressure and dietary guidelines since its initial publication. So why isn't everyone doing the DASH diet, or hypertensive patients? National Health and Nutrition, the NHANES study, I'm sure everyone heard that, showed that less than 1% of the U.S. population was fully adherent to the DASH. Only 20% met half the recommended requirements. And public health significance of a poor DASH diet cannot be underestimated or overstated. 80 million people in the United States have hypertension, only half have controlled blood pressure. It's a pretty staggering number. Now, why is there poor adherence to this? It attributes the first current food, U.S. food environment. Energy-dense, nutrient-rich foods are deficient foods, are highly accessible, and they're cheap. They have sugar, they have gluten in them, they have soy, they have a lot of processed foods are very easy and they're easily accessible. Just walk around the city of New York. Particularly true of low-income individuals who may reside in areas where DASH foods are less than acceptable. We talk about a lot of food deserts in the city and food throughout the country. Despite these barriers, DASH can be adopted. You have to use dried beets, frozen vegetables, inexpensive, and even in our DASH accordant. In 2003, they suggested if individuals with hypertension were fully compliant, an estimated 400,000 cardiovascular disease events could be prevented over 10 years. So what is causing this? So if you look at, this is out of England, they did a very nice population-based study in the UK, and they looked at sort of, if you look at lower, as income rises, the DASH score, which is the number of components of the DASH they're doing, also increases, as well as in education. If If you're more educated, then you're more likely to be compliant with the DASH diet. So what are some other popular diets out there? There's the who's heard of the flexitarian diet? Oh, okay. So this encourages people to eat vegetarian most of the time for better health, but doesn't call for cutting meats out entirely. Weight Watchers, I'm sure we all heard of. It's a very popular diet. Oprah is endorsing it. It works on a point system. Each food's given a total number of goal per day. So if you have a sweet or piece of cake is a higher point system than carrots or broccoli. And the problem with these diets are they're prepared, they're processed, and so there's not really a sort of a cleaner diet that some people talk about. There's the MIND diet, which is sort of a cross between the DASH and the Mediterranean diet. It's supposed to help brain function and prevent Alzheimer's. There's still research to see if this actually works. People are encouraged to eat 10 brain healthy foods a day. Greens, vegetables, nuts, berries, beans, fish, poultry, olive oil, and wine. They're also told to avoid red meats, butter, stick margarine, so high trans fat, cheese and sweets, and fried and fast food. There's the TLC, the therapeutic lifestyle changes, meant to help prevent people cut down on high cholesterol and eat more fiber. Whole30, who's heard of this? Okay. So this is from Melissa Hartwig and Dallas Harvest started this up. 1 million copies sold. This is when you Google this is what pops up. It's 30 days. It claims to manage allergies, digestive issues, and chronic pain. This is not a weight loss diet. There's no sugar. There's no alcohol. Cooking wine, you can't do that. Grains, legumes, and dairy. There's no cheating. You can't chew gum, sweets, anything. There's no data. But eliminating dairy, but the problem with this diet, and then I look it up, is you're eliminating, dairy. You're eliminating dairy, grains, and legumes. You're eliminating 3 components, not dairy, but the grains and legumes of a healthy diet that we know. And so you're losing calcium, you're losing vitamin D. You could set up for other like thiamine, other deficiencies. You're going to cut out thiamine, folate, particularly because a lot of the grains are fortified with folic acid. And also punishes people for slip-ups and sets them up for failure. It's sort of a short fix. But everybody looks for a short-term quick diet. Everybody wants that.
Guilt with the chronic pain.
Yeah, exactly. It's like you're getting double punch while you're down. The keto diet. I'm sure most people have heard of this. Atkins really published this diet in 1973, again in 92 and 2002. And that's probably the most well-known of this form of diet. It's a low carbohydrate intake. The theories results in a reduction in circulating insulin levels, which promotes high circulating fatty acids used for oxidation and the production of ketone bodies. So there's been a lot of literature, a lot of studies on this, and there's more and more coming out every month. So 1-year multi-center randomized trial, they evaluated the Atkins diet on weight loss and risk factors for coronary disease, traditional high carbohydrate diet, the low-fat diet, so it was 1,200 to 1,500 kilocalories per day for women, and 1,500 to 1,800 kilocalories per man. 60% of the diet from carbohydrates, 25% from fat, and 15% for protein. The patients on the low-carbohydrate diet did lose significantly more weight than the subjects on a conventional diet over 6 months. The difference in weight loss was not statistically significant at 12 months, though. So you'll see this some slides later. There's a big drop-off, and then they kind of come back up. So looking at a low-carbohydrate diet comparing to a conventional diet, triglycerides and the low-carbohydrate diet dropped. You had a look in total cholesterol. The low-carbohydrate change went up. Actually, went down. The change in LDL cholesterol, low-carbohydrate diet percentage increase, and then again the change in HDL. You had a significant increase in low-carbohydrate diet compared to the conventional diet. So what are the physiologic effects going on? During the first 3 months, the percentage points, they looked at urinary ketones, and the first 3 months you were definitely ketotic. You had a higher incidence of positive urinary ketosis, significantly greater on the group in the low carbohydrate versus the conventional diet. But after 3 months, this was no longer significant. So it wasn't just this physiologic effect that everyone talks about, putting you in a ketotic state. There was no significant relation between weight loss and ketosis at any time during this study. No differences between insulin sensitivity between the low carbohydrate and the traditional diet. Both groups had significant increases in insulin sensitivity 6 months, but they were not different at 1 year. Lipid profiles, again, high carbohydrate, low fat diets decrease HDL, concentrations increase serum triglycerides, and low carbohydrate, high fat diets decrease triglycerides and increase HDL. But what's the nutritional quality in some of these diets? There's very little data on this. There was a study done in 311 women. They were placed on 4 common diet books: the Atkins, the Learn, which is lifestyle, exercise, attitudes, relationships, and nutrition, and the Ornate, which is so let me back up. So the Atkins diet was you started less than 20 grams per day of carbohydrate on the induction phase, and then the ongoing weight loss phase less than 50 grams per day. They did about 3 months to 6 months, but they didn't really specify when you'd actually go from the induction phase to the ongoing weight loss phase. The Learn, which is eating based on the USDA pyramid with a goal of 1 to 2 pounds per week of weight loss, sort of a traditional understanding of what a diet is. The Ornish, which is eat more, weigh less than 10% of fat, so it's a low-fat diet. And Enter the Zone, which is about the Zone diet. It's a 40-30-30 carb, protein, fat, less than 500 kilocalories per meal, less than 1,100 per day, so 1,700 kilocalorie per day diet. And they're watched for 2 months. And they used a 3-day unannounced 24-hour food recall on the patients. The baseline groups are similar in macros. So macronutrients are protein, fat, carbohydrate, micronutrients, again, vitamins and minerals. And then although it's recommended in the Atkins diet, and these patients on a keto diet are supposed to be on a multivitamin, only 3 out of 73 of the patients actually went on one. So this is something always to think about when you see if you have a patient that's taking the Atkins diet. So the thing that I found interesting about this table was looking at saturated fat, again, significantly higher, 31 grams per day, saturated fat 20 grams per day when you compare it to sort of the Ornish or the Learn diet. Monounsaturated fat was much higher in the Ornish diet, but also it was lower, in the Ornish diet. And then the fiber, again, only about 11 grams per day in the Atkins, as opposed to, say 22 or even 17 in the Zone. These patients really aren't getting dietary fiber, which is not surprising. The vitamin and mineral intakes by the diet group, there's a lot on this slide, but the things that sort of struck me were, again, you're looking at the setup for deficiencies in vitamin C. Again, this consumption was low. The B12 was not really much difference between the 3. Vitamin A, again, was higher. It was high in the Atkins Zone, but low in the Ornish. Thiamine, again, was very low in the Atkins diet, not surprisingly if you're not getting many grains. Proportion of participants in risk deficiency. This is sort of the slide that I really kind of like from this talk, from this lecture. It was, article. It was 26% of the Atkins diet at baseline were deficient in 18, because obviously vitamin A and eggs, things like that, which are high. But if you look at the vitamin C, 32% were deficient. Then you have 52% of the Atkins patient at 8 weeks were low. Vitamin E, there was low. The Ornish, in the zinc, again, 16%, then it went to 7%, so that was a nice improvement probably from seafood consumption. Magnesium, they were low. So, and again, take this with a caveat, if some of these patients went on a multivitamin, hopefully you wouldn't see some of these deficiencies. And that's sort of what I wanted to stress, particularly with the Atkins diet. Non-gluten celiac sensitivity. We all see this. And this is basically characterized by intestinal and extraintestinal symptoms related to the ingestion of gluten. Patients do not have documented celiac disease, negative TTG. They may have had enough endoscopy and already had duodenal biopsies. They have bloating, abdominal pain, fatigue, and migraines, like irregular bowel movements. Is this really weak? Is this really due to the gluten? Wheat contains fermentable oligosaccharides, disaccharides, and monosaccharides as part of the FODMAP. So this may not be a gluten sensitivity. It may be a wheat intolerance. So what is a gluten-free diet? So gluten-free products are inherently gluten-free. They do not contain a gluten or containing grain, or they have gluten that was processed to contain less than 20 parts per million, according to the USDA. Similar cutoffs in Spain, Italy, and Canada, and the UK. Australia, I believe, is around 3 or 4 parts per million. They're lower. What are gluten-free grains? We know oats, as long as they're processed in a facility that doesn't also process other grains: rice, corn, quinoa, flax, yucca, nut flours, beans, and soy. There's no evidence intake of oats with a gluten-free diet will change symptoms, histology, immunity, serology. So as long as they're gluten-free oats, they're safe. And this is sort of a slide for you to look at, but basically hidden sources of gluten. So oats, sauces, or marinades are a big thing I always ask my patients. Are you doing any, when you go out, are you getting the fish or chicken grilled, or are you getting it marinated with the sauce? Drug fillers can happen in processed meats, shared food preparation, toasters, fryers, pasta, and pot. I think those are here for Sheila Crow's to talk. I think last year she talked about, making sure you just wash the pans and wash the, but as long as you wash the pans and wash the cutting boards, you're usually fine. Church communion, that was on my boards, interestingly, and lipsticks and chopsticks. So really gluten is in a lot of products. It's pretty remarkable. So what are the nutritional considerations someone on a gluten-free diet? So this doesn't apply just to the patient celiac. This applies to someone with gluten sensitivity or someone that just wants to go on a gluten-free diet for supposed health reasons. They're high in saturated fat, lipids, sodium, and calories. They're lower in zinc, iron, calcium, folate. They're low in fiber, sometimes low in magnesium. Patients will need to be constantly eating iron-rich foods, meat, soy, beans, leafy vegetables. So basically they're eating high fat, high sugars, and high salt. Yes.
The biggest problem with the gluten-free diet is people who use gluten substitutes. So when you get the gluten-free breads, and the gluten-free muffins, and the gluten-free candies, because those are the things that are high in all these fats.
Exactly. That's sort of what the.
If you just avoid gluten-containing products and stick to like oats and let's say rice, and you're not eating all that other stuff. You're eating mostly vegetables and let's say fish and things like that, and avoiding all these quote gluten-free substitute products that allow you to eat muffins and breads and things like that. You're not getting as much of these bad actors.
Correct. The problem is that
But everybody wants to have the muffins.
it's ready-made. Everyone wants muffins. Everyone wants chips. Everybody wants to eat the things they used to eat before they were either diagnosed celiac or they realized that they don't tolerate wheat. So I'll get into some. Thank you for the lead-in. I'll get into some of that. Yeah, and I think also it's a time factor. It's an availability factor. If you look at prepared foods.
Why do they need to eat iron-rich foods if they
Well,
don't have celiac disease?
They don't, but I think that's sort of a general consideration if they just encourage them to eat a healthy diet, because some patients tend to avoid everything. Oh, I ate meat because I looked at this diet. My theory is that they say that particularly marinades, things like that, they have to be careful. So some people just avoid everything and they're like, oh, I can't eat this, I can only eat eggs. And then so I just try to, oftentimes when I see them, they just eat I eat oats, I eat oatmeal, I have eggs, and I have a little bit of tea, and that's all they can eat. And they're just not eating a healthy diet. So that's a good point. I just meant that they need to be able to eat a really rich, they can eat a nutritionally rich diet, sort of what Jim was talking about. It's just you have to encourage them. Because if you don't really screen them, they could be eating a very bland diet. But technically, red meat does not have a gluten-free diet. But you don't have to avoid red meat on that. So they looked at the the N. Haynes study. This is in a Mayo Clinic where they actually went back and looked at the blood samples of patients. And there's a lot in the literature, some stuff came out last year about the problems with some of these gluten-free products. Patients had increased levels of mercury on a gluten-free diet compared to persons not on a gluten-free diet. They had increased levels of lead and cadmium. Urinary samples of patients on a gluten-free diet had concentration of total arsenic than from samples of patients not on a gluten-free diet. Individuals without celiac disease, so these are patients without celiac disease on a gluten-free diet, about 101 out of 10,000 patients had increased levels total of mercury, so 1.4. Also patients, higher concentrations again of lead and arsenic again. Blood samples of individuals with celiac disease avoiding gluten had levels of cadmium again. And then also the thing is that another study, they looked at urinary concentration of arsenic associated with consumption of rice, which is a major staple in gluten-free products. So, the theory is that bloodbird from California rice does not have as much as sort of rice from Asia and other countries. But that's sort of the big risk factor that's coming down in the literature, and I've had patients ask me about this. So really, as you said, the less prepared foods, the more wholesome and fresh ingredients we eat, the less likely that's going to happen. Yes?
Other than stoking their already considerable anxiety, which is fueling their gluten-free lifestyle to begin with.
Mm-hmm.
Go back a second on the slide. I mean, you see lead, you see arsenic, the numbers seem, they're micro
Right.
grams.
We don't.
The difference between 1.44 versus 1.13, while statistically significant, it's neat.
Well,
this is just meaningful at all.
Yeah. It's meaningful in the sense that, look, arsenic is natural in the environment. This is not something man-made. But it's just something to be aware of, because these gluten-free products are heavy rice-based and because they're not sort of part of our old traditional diets, it's just something to be aware of. They don't know what the health consequences of these levels are yet. This is just, these are observations. I think it's just something if patients come to you and ask you these questions, I would probably say, look, we don't know for sure in terms of the toxicity of these metals, but I do think that it would encourage them to make their own food, which I do to all my patients. I tell them, cook, prepare your own foods. If you do go out, make good choices. Like I said, grilled meats, grilled fishes. Tell the waiter you have selectively gluten sensitivity. Sometimes they roll their eyes, but I think in general, you're right. Patients are already anxious, and I wouldn't bombard them with everything in the first time, or they may not come back. So
I've been reassuring patients, maybe not reassuring, but countering to say, doctor, I want to eat more naturally, and I want to take a natural approach to my Crohn's disease, for example. I said, well, our skin is natural.
Yeah,
now you just completely bolstered my argument.
It is natural, but we're consuming probably an unnatural amount on a gluten-free diet. And this is really for the patient. Look, the patients that have full-blown have documented celiac disease. They want to live their own life. Just everything in moderation. Right? Patients, they have to recognize. Some people can't do milk anymore. They just don't have milk. Yes.
It has to be like to try to counteract what I consider pseudo disease. Because most of the people that have this kind of sensitivity, they consume large amounts of complex carbohydrates, even without gluten, which may be causing part of the problem. Being things that just fruit, the more you would do it too. So this may be a way of dealing with the large food processing companies that are now making trillions of dollars a year. And in fact, you're getting up and talking about this, I'm afraid there's going to be a hit on it.
I think that you're right. It's last time I looked, it's over 20, 25 billion, I think, or something spent on gluten-free products a year. So it's huge amounts. And it's a huge business. We have Adherence. We're partnered with Mount Sinai, and they are a gluten-free, low-fat MAP company that's a food delivery service.
What
there's
about complex carbohydrate intolerance?
well, that's true.
They're
And I
blaming it
think
on protein.
what?
They're blaming it on gluten.
But it's not, and that's my point. It may not be gluten. It could be some of the FODMAP, which we talked about earlier, from the gluten-free product, from the gluten products or containing products. 30% of the U.S. population is minimizing or avoiding gluten due to concerns of obesity, cardiovascular disease. There are all these health claims out there where gluten is bad for you. Looking at a prospective study of over 2 million person years, no increase of heart disease. And this is also the thing about gluten-free diets. We're reducing the beneficial intake of some of the grains that are there. And these are really good for health reasons, not non-gluten gluten sensitivity or celiac disease. Okay. So had they compared diets? Had they looked at them head-to-head? So in a 2-year dietary intervention randomized control trial, the DIRECT trial, compared the effectiveness and safety of 3 nutritional profiles: low-fat, restricted caloric diet, a Mediterranean diet, and a low-carbohydrate diet. Age 40 to 65 years, BMI of at least 27, the presence of type 2 diabetes or coronary disease, regardless of age and BMI. Low-fat, restricted caloric diet based on the AHA guidelines, 1,500 kilocalories per day, 1,800 kilocalories for women, and about 1,800 calories a day for a man. 30% from fat, 10% calories from saturated fat, and an intake of 300 milligrams of cholesterol per day. Mediterranean diet we talked about, but really the goal of no more than 35% of calories from fat. Main sources of fat were about olive oil, a handful of nuts, 1,500 calories a day, about 1,800 calories again for women, and the Atkins diet, which was did not restrict calories, but aimed for 20 grams of carbohydrate for the first 2-month induction phase. And immediately after religious holidays, interesting point, and then the gradual increase to a maximum of 120 grams per day to maintain weight loss. Intake of, again, calories, protein, and fat were not limited. So they did this actually in Israel, and they had a workplace research center. So on site, at least for lunch, they actually consulted with dietitians, and they actually had provided lunch, which was nice, and they actually had choices and labels of all the calories, fat. They broke down the nutritional macronutrients of each food so patients could make good choices. They followed them for 2 years. They did questionnaires, blood work, weights were also collected. About 95% of patients were adherent at 4 months and 85% at 24 months. The low-fat diet, At 24 months, the low-fat diet had about a 90% adherence rate, Mediterranean about 85, and the low-carbohydrate about 78%. So looking at the weight loss, the mean weight change, you sort of see again this sort of the low-fat diet has this sort of drop-off, big weight loss about 6 months, and then patients slowly start creeping up as they start adding back in their traditional foods. The Mediterranean diet had a similar drop, but then sort of the patients were able to maintain their weight. And the low carbohydrate diet, again, had even a bigger weight loss at 6 months. And then they slowly started increasing back up and sort of nearly close to where the Mediterranean diet was, which is interesting. And this is sort of what patients see. They go initially in the Atkins diet, low carbohydrate, they have a huge weight loss, and then as they sort of reintroduce the foods they used to eat, they gain weight back.
Wasn't the low carbohydrate arm also calorie restricted?
They were also calorie restrictive, all of them. So that they all were proportionally similar calories, except for the low carbohydrate diet, where they're allowed to do whatever they want. You don't, but a lot of times in the literature, they show that patients on a low carbohydrate diet eat less. So it's not, and some of the theories out there are that the low carbohydrate diet actually is restrictive in the sense it's self-restricted. These patients get full. It's a high-fat diet. Fat empties the stomach slowly. You're full longer, and it's high protein, so patients don't eat as much. And that's sort of what ends up happening on a lot of these diets. They're not eating 3,000-4,000 calories a day on a low carbohydrate diet. That's a good point, Steve.
There's the whole notion of portion control, just total calories.
Yeah.
My 103-year-old grandmother who passed away was skinny as a rail, and when you asked her what's the secret to living to 103, she said, in her Yiddish accent, she said, I never had what to eat. She never ate a lot. And it was all portion control.
Yep.
And she had high cholesterol, actually. It was portion control. N of 1.
My late grandmother and my dad's side, she had a cholesterol through the roof. HDL was through the roof. She did great. She didn't eat a lot. Yeah, I mean, it's one of those things that all these diets, sort of my take-home point, I'm jumping ahead, and I'll get to it, but it's like I said earlier, what goes in, what goes out. It's
There are 8
really very
calories in
simple.
a gram of fat, there are 4
9.
calories in protein. Wendy's, they measured the hamburger versus one of their olive oil coated salads, which had a ton of stuff in it. And the caloric content of the salad was greater than the hamburger. They've done this.
I know they've done this in McDonald's. They've done this. There was
the sitting there with this hamburger is taking in less calories than somebody who thinks they're doing themselves a favor.
Well, there's a lot of additives in them. A lot of times these salads have like candied pecans, and they have salad dressing. And olive oil is not bad. I mean, calories.
A gram versus 4.
Right. Well, true. But so if you have 9 grams per gram, in a lipid, which is general, it's very surprising. But you have to understand that just because there's more calories means it's bad. It's the total amount you take in. So someone goes to who goes to Cheesecake Factory? Everybody's running out with doggy bags, and they come out and you get a salad this big. It's like 2 heads of lettuce, and they've done this, and it's tons of additives. They have probably a half a bottle of salad dressing on there, and it's and then they wonder.
The fat lowers slows gastric emptying, so there's better satiety, and there are hormones that secreted that actually slow gastric emptying.
Right.
So that may be
So briefly looking at the slide, a lower intake of carbohydrates, higher intakes of protein, total fat from the low carbohydrate diet. The low fat had lower intake of saturated fat than the low carbohydrate group. The Mediterranean diet had a higher ratio of monounsaturated and saturated fat and a higher intake of dietary fiber, which is important. The portion of patients who had detectable urinary ketones at 24 hours were higher in the low carbohydrate, 24 months, were higher in the low carbohydrate diet than in the low fat group and the Mediterranean group. At 24 months, the weight changes among 277 males versus the 45 females. One problem with this study is they did not have a great enrollment of women proportionally. Low fat had 3.4 grams versus 1 kilogram. The Mediterranean had about a 4 kilogram weight loss versus 6.2 with the women. And low carbohydrate of 4.9 versus 2.4. LDLs did not change significantly. Adiponectin increased significantly in all diet groups with no significant difference among the groups in the amount of increasing. Leptin, again, reflects body mass, and not just significantly in all groups, but not simply different among the groups. So just to take a time, the fast diet, let's go to this. This is really popular now, it's catching on. The whole concept is you live longer, lower diabetes, heart disease, fights inflammation, promotes growth hormone. So fasting between 5 to 24 hours at a time, or they decrease to one meal 25% of the previous amount. So you're just basically eating less of a meal. They claim improves brain function and longevity. Intermittent fasting is restricting feeding period emerged from religious and spiritual traditions. Ramadan, people in the Muslim faith fast all day. Jewish people, we do this once a year, and we all complain. But on Yom Kippur. But the most studied type of intermittent fasting occurs, like I said, in Ramadan, and there's some data on weight loss and some data on lipid profiles. The majority of studies analyze the impact of intermittent feeding or intermittent fasting on the lipid profile, but they're observational and they lack informed information about the actual diet. But this is definitely out there, and there are patients on this. They looked at one study of intermittent energy restriction versus sustained energy restriction. So this intermittent fasting versus just cutting your calories every day. They looked at obese patients. They decreased 26 to 8 kilojoules is a British study, or 25 10 kilojoules looking at over the overall energy restriction. They did post-plan response to a test meal over 30 to 60 minutes. Changes in fat mass, fat-free mass, waist circumferences were assessed. They found no difference in the time to attain 5% weight loss between the groups. And all foods are self-selected by the patients. So really, there are patients on there. There's a lot of books on there. There's websites on this. So this is out there. And just be aware, but if patients ask you, just tell them there's really not a big difference between intermittent fasting and sustained energy restriction in terms of overall weight loss. And plus, there's this theory of, you can have a rebound, ravenous, you're hungry, and then you eat more. So I think that's but this is more just a FYI. So mindful eating is the last thing I'm going to talk about. And this is basically a non-diet emergent approach to healthy weight management. It's based on awareness and physical emotional sensations associated with eating. It may help individuals adopting this approach recognize they respond to internal cues of hunger and satiety. Mindful eating is based on reducing obesity-related behaviors, so promoting weight loss, reducing physiologic stress. How these effects are driven is unclear, but it has been shown to be effective. Most of these are small trials and observational studies. These are some questions that I've teased out of literature. Before I eat, I take a moment to appreciate the color and smells of food. I notice when the food affects my emotional state. I taste every bite of food I eat. I appreciate how my food looks. I notice subtle flavors. I recognize when I'm eating and not hungry. Recognize how food advertisements make me want to eat. When I eat a big meal, I notice it makes me feel heavy or sluggish. I will continue eating even when I'm full. When a restaurant portion is too large, I stop eating when I'm full. This is all the idea of this is to make you mindful of what you're doing and try to be cognizant in terms of what your dietary. A lot of these are in behavioral health literature. A lot of this, it's done, and it's interesting. It's an interesting concept, but I don't think this is a cure-all. But it does the idea is just behavior modification in terms of diet. Yeah, your question. Someone had their hand up. Oh, okay. So what do we need to do? We need to tailor weight loss plans specific to our patients' food preferences. Exercise needs to be a part of a weight plan. I didn't get into that today. For time's sake, if patients are on a diet, I would just consider putting them on a multivitamin, just for general health, particularly if it's any kind of restrictive diet. Consider screening obese patients for micronutrient deficiencies, and then feel free, if you have questions, to contact myself or a local dietitian for any further assistance. Questions? Oh, sorry, one more second. Thank you.
There you go.
That's the New York diet. That's the New York diet.